Thank you for coming. It gives me great pleasure to welcome you to our Stowood Sleep Symposium. Founded by my father, Lynn Davis, Stowood is celebrating 30 years of innovating sleep diagnostics and looking forward to celebrating the next 30. As part of our contribution to the field of sleep, we have introduced the new VisiDownload 2 software, a free upgrade to anybody who has a VisiDownload license. Please join me at the Stowood stand sometime in the rest of the conference to receive a live demo of the software. As part of the launch of VisiDownload 2, we have sponsored the BSS to allow Dr. Yanni to talk about diagnosing sleep-disordered breathing in secondary care. Dr. Michael Yanni is a consultant paediatrician with an interest in respiratory medicine, working at Stowood Foundations Trust for the last 15 years. Michael has established a novel paediatric sleep service in secondary care based on the use of limited multi-channel sleep studies to improve the detection of sleep-disordered breathing with published results of experience. Michael was a member of the Guideline Development Group and co-author of the recently published PTS Guideline for diagnosing and monitoring pediatric sleep breathing. So please join me in thanking Dr. Yanni for sharing his research and his experience in this talk. Dr. Yanni.
Thank you, William, and thank you especially for the invitation. It was a surprise to be asked, but it's an opportunity for me to be able to talk about some things that are of real interest to me, and I hope to you as well. So, just to say, I have no conflict of interest, so it's invited to do the talk, but I'm not being paid to do this. The things that I thought I'd talk about are some of the tools that we've sort of looked at in the new BTS guidance, as far as things that would be suitable for use in secondary care. So we're all aware that PSG is a gold standard test for diagnosing sleep-disordered breathing in children, but that's not something that's accessible to us in a DGH. So the focus here really is to look at some of the tools that can be used in that setting. I'll talk a bit also about our experience of using a limited multi-channel study, so not quite the same as polygraphy and all the extra bits that go with that. And also of interest to me is pulse transit time, and I'll share a little bit of our experience with that and our findings with that. So why do we need tools to help us diagnose obstructive sleep apnea? So I've changed from sleep-disordered breathing to obstructive sleep apnea to sort of home in on the children that we're most interested in. So you'll be aware that sleep-disordered breathing is a spectrum of disorders ranging from primary snoring to OSA at the top end of the spectrum. And what seems to be the case is that wherever you are on that spectrum, the symptoms that parents report are the same. So it seems to be that children with primary snoring often present with snoring and possible apneas, and children with definite OSA. It's hard to distinguish between the two ends of the spectrum just based on symptoms alone. And the reference at the bottom there by Wang et al. Was quite a revelation in showing that about a third of the children where clinicians thought they had OSA when they did PSG, using the strict criteria of PSG, only 30% of them met that criteria. So, yeah, so this is just a picture to sort of highlight what's involved when we're doing PSG. It's a complicated business. It's not for us in a DPA setting. That's for the clever specialists. This is just a polygraphy trace. I did have one of PSG trace, but this is also complex. There's lots of channels being monitored, and again, it's not really that accessible to us in a DGA setting. And I think, excuse me, part of what we hoped to achieve with the new guidance was to basically make the diagnosis of sort of breathing more accessible to everyone. And so as part of that, we looked at a number of different tools, and we looked specifically at how effective, how accurate they were, so that when we're using them, we can have a good sense of how reliable the results are. So the top two that were covered in the guideline that would be relevant in secondary care are the questionnaires and oximetry. We did look at the evidence for video and audio recordings, but there was very little data there. There was only one paper for each of those two that was of sufficient quality, and we couldn't really include advice about what to do about those in the guideline because of how limited the data was. And the last two, there's limited data, but not sufficient that we could include in the guideline. But I'll just talk a little bit about my experience of those two, the last 2 points there. And in the guideline, we just wanted to clarify what level of sensitivity and specificity would be considered good, or high, very high, or low. And those are the sort of percentages that we were looking at. So I know this is a busy slide and difficult to read, and I don't expect you to read most of it, but I just wanted to highlight, if I can get my pointer working. So yeah, it was just to let those numbers up here. So for these 2 questionnaires that we looked at for the guideline, the sleep-related breathing disorder PSQ questionnaire and the OSA 18, basically had the best evidence of all the questionnaires that are out there, and probably the best sensitivity and specificity. And the pooled results are, as you can see, so they're moderately sensitive, but low specificity, meaning that they'll pick up maybe 80% of the children who have got the disorder out of the pool, but when you get a positive result, it's maybe 50% likely that child will actually need surgery, or less than, depending on which of the numbers you look at. So they're useful, I think, but it's important that you're aware of that as a limitation. The other type of questionnaire was a questionnaire where you also had a clinical evaluation as part of the assessment. So it was not just a sort of standard examination, but a sort of protocol-driven evaluation, clinical evaluation, alongside your questionnaire. And that improves the sensitivity and specificity, but we're still only looking at a low level of specificity, even though the sensitivity is increased. And one thing that we noted was the sleep clinical record, even though the sort of output of how useful this might be looks good, the sort of usability of it was questionable. It would probably take a good half an hour to do that, clinical record assessment. So we're not sure how many, how useful that would be in a clinical setting. But the CAS-15, on the other hand, is a sort of a 10-minute, 15-minute assessment. So that may be more user-friendly, but those are the limitations of the questionnaires. So what about oximetry? So that's something that we're all familiar with, and I've just put up an illustration of the different ways that you can, the patterns, if you like, that you might see with abnormal oximetry that might help you to make a diagnosis. These numbers from Roulet's paper from about 20 years ago were what I'd always understood as the sensitivity and specificity for oximetry. And you can see that oximetry, from their data, oximetry is very specific. So if you get a positive result, it's helpful. But the sensitivity, as I understood it, was low. However, when we did the diagnosis and looked at more recent data, so that paper was obviously from 20 years ago, looking at more recent data, the numbers are actually showing that oximetry is better than I thought anyway. I don't know if others were aware that the new data coming that's been published since shows that oximetry is actually not bad at detecting children with OSA and being specific. And I think the figures that are worth being aware of is for children with no comorbidities, oximetry is actually quite specific. So it falls down, oximetry falls down in children who might have comorbidities, who might have a complex background of neurodisability or sort of craniofacial anomalies. So those children, we need to be wary of oximetry and interpreting oximetry, and maybe children with Downs who might have central apneas. But in children without comorbidities, it is actually quite good as a tool. And these are some of the indices that might be useful for working out if oximetry is positive. So the ODI-4 of greater than 4 dips an hour, or ODI-3 of greater than 7. And we looked earlier at the sort of patterns of clustering and depths of desaturations, which can also be helpful in working out not just if it's positive, but how severe it is, how severe the OSA is. So I did say that we looked at the evidence for sleep video recordings and sleep video recordings and audio recordings. There was just that one paper, as I said, for the sleep video, which was a home video where there were some sort of defined characteristics that parents had to look for and try and video, and those were scored by a clinician, and that actually had quite a high sensitivity, so it was good at detecting OSA if it was there, but the specificity was just into moderate, so just a bit better than low, so it was moderate specificity. And the home sleep audio had even smaller numbers. There was only 29 in that study, but yeah, the sensitivity was low, the specificity was okay. But what I would like to talk to you about next is combining oximetry with video and sound, which is essentially what we've been doing in our trust. And I was just going to sort of walk you through how that works. So this is just to illustrate what the technology looks like on a child. So we have here a very mature teenager who's modelling the equipment for us. But yeah, so all they have, the children just have that box and the oximetry probe. They have ECG leads, which plug into that. So nothing around the face. And there is so we have a high quality infrared camera in the room and a microphone which is not attached to the patient but in the room as well. So it has its advantages of keeping their face free, but a big disadvantage of the microphone in the room is frequently we pick up parental snoring as well as child snoring, so it's not uncommon for us to diagnose a parent's OSA at the same time as declaring the child to be free of OSA. But this is what a trace would look like. So we've got oximetry at the top, heart rate next, the movement is the green spikes, and the sound is the red channel. And then you've got pulse transit time just below. And this is an example from a child I saw just last week who very clearly had OSA. And what we often find is you can sort of flick through the trace and they'll have periods where they're just snoring without any disturbance of the oximetry patterns, but then suddenly you get these periods where you've got a sort of sinusoidal trace. So OSA is quite easy to pick up with this. We've also got the oximetry data before we start, so we start off from a position of knowing, oh, this is a child who's got an ODI of 8, so they already meet the criteria for OSA just on oximetry alone. And then we look at the trace, and if it looks like that, we go in to have a look at what the video looks like in one of those periods. And this is a trace that doesn't show very much other than snoring. So you've got the snoring channel, but no sort of variation in the heart rate or no movement spikes. So this is just a sort of very short clip of what we're looking for when we see that trace. So the way we use our equipment is we start off with the oximetry, we then look for those patterns in the trace, and then we go in to look at a section of video if we can see from the trace that there's either variations in the oximetry or heart rate or movement spikes. And we're looking for signs that there's that sort of pattern of breathing. And if the oximetry is abnormal and the video is abnormal, then we would diagnose that as OSA. If the oximetry is normal, but we still see the video pattern of abnormality, then we call it upper airway resistance syndrome. And technically that's probably, those children, some of them would probably fit a diagnosis of mild OSA, but we haven't quite got enough to call it that. So when we say to our ENT surgeons, what we say to our ENT surgeons is we think they may have mild OSA or upper airway resistance syndrome. And then the third group, where we just see the snoring pattern and there's no obstruction on the video, we would say that's primary snoring, and sometimes it's a completely normal study. And every now and again we see a child with abnormal oximetry, but no obstruction. So we can't find any signs in the video that they've had the sort of pattern of obstruction that I just showed you. And those might be children who say have got a central problem, like a child with Downs who has a combination of central and obstructive episodes. So that often will explain the abnormal oximetry. So you saw on that first trace that the PTT signal was abnormal, just in line with all the other parameters, and that's been an area of interest for some time. So this paper, which is from about 20 years ago, highlighted the fact that PTT might be useful as a way of detecting arousals, children who may not necessarily be desaturating, but having frequent arousals. And there was a lot of research that followed this, but unfortunately the results were disappointing, and I think part of that was the focus was on the use of a particular PTT index, the arousal index, so PTT-AI. And this is just illustrating what PTT is. So it's a measurement that is worked out from the ECG and the Polysomnography reading. And it's basically that measure of the R wave and the oximetry pulse, the time it takes between those 2 points. And the 2 different measurements that you can get from pulse transit time are the arousal index, which I've mentioned, but the other is the respiratory swing, which up until now I don't think has had as much attention. So I think most of the earlier publications about pulse transit time focused on the AI, and that's been a bit of a disappointment. This is just a slide showing how the PTT is affected, what sort of affects it. So we know that if you're obstructing and having frequent arousals, then your blood pressure goes up and that causes the PTT to shorten. On the other hand, if you have significant respiratory obstruction, you develop quite a pulsus paradox, then that causes your blood pressure to drop. And so those are the 2 ways that the PTT can be affected. So it can be a measure of arousals, but it can also be a measure of your respiratory effort. And so this is some research that was done by the team at Great Ormond Street using the same equipment that we just showing you. And this was published as an abstract 2008. And it showed the trend of an increasing pulse transit time, both arousal index and respiratory swing. This was about 280 children they looked at. So we did a study where we looked back over a 2-year period of the children that we've been doing these studies on. And we looked at how the oximetry compared with the use of the multi-channel study, as well as a smaller group who had PTT, who had enough PTT data. So there was a lot of PTT artifact, unfortunately, but so yeah, we had to exclude a lot of data. But on the oximetry front, we found that using the multi-channel study, we pick up an extra 112 who would be missed by oximetry. So these are children where there's video evidence of obstruction, but no abnormality of the oximetry findings. And so, yes, that's about 182 out of a total of 520. So about just over a third, or around a third of the children who come for a sleep study, we find an abnormality in either of those 2 ways, either with abnormal oximetry or just with abnormal video. And these are our PTT results. So on the right is the arousal index, the PTT-AI, which, as you can see, it's not really differentiating between the 3 groups and this is in sort of real-world data, as opposed to in a research study where they've sort of had smaller numbers. but the PTT swing is consistently, showing that there's a trend there showing that it's higher in those with either OSA or UARS as we've described them. And this is the sort of confidence interval. So if you're using just around 18, a number of 18, it's got the best sensitivity and specificity. So that's the sort of best combined number to use. But over 20 is quite specific, but less sensitive. So we think that there's something that needs, that could do with being looked at in a more rigorous way. So if we could get a study where this type of way of picking up both OSA and also the PTT findings could be validated with PSG, we might then increase how useful it is. So that is a study that needs to be done. There's only one study so far that's compared the two. It only had, I think, 10 patients in it. There was fairly good correlation, but it's too small a study for it to be accepted more widely. So yeah, I think that work needs to be done. So yeah, to summarise, I think questionnaires are useful. I think they're better than just a straightforward history or straightforward examination. A structured questionnaire is useful. I think oximetry is quite useful. It's quite accurate in the right group of patients, but it's important to know what the limitations are of oximetry. I think post-transit time, there is still potential there. That still needs a little bit of work for more wider use, but I think our numbers suggest that it's something that really could do with looking at more rigorously, and also the sort of use of the multi-channel studies in the way that we're doing it. And I'd just like to acknowledge the people on this slide. Dr. Nabil Ali was the person who had the vision to kind of start the program that I joined as he was starting it. So he should take the credit for what we've done. I've got people who've helped me with my stats. And I'd like to also acknowledge Paul Gladding at Stowood, who's helped me with a lot of my sort of research when I was trying to get my head around what the PTT actually is. He's very helpful. And also helped us to try and see if we could reproduce PTT swing from other types of equipment, so not just the Stowood equipment. He did his best, but we didn't quite get there. But anyway, thank you. Thank you for listening. I